Namaskar and good evening, everyone. I welcome you all for today's webinar on newer paradigms in the management of mNSCLC. With immense pleasure, I would like to invite Dr. Dattatray, who is Senior Consultant Medical Oncologist, Renova Hospital, Hyderabad, for the welcome and introductory note. Over to you, sir.
Thank you so much, and a very warm welcome to all the faculty members and the delegates assembled for a discussion and lots of learning in the recent advances and newer paradigms in the management of metastatic non-small cell lung cancer. I think all of us agree that a lot has happened in the treatment of metastatic non-small cell lung cancer when compared to any other cancer. We now talk of mutations, and especially in the EGFR mutant NSCLC background, we now know that even that subpopulation you find at least 4 buckets: E19 deletion, L858R point mutation, exon 20 insertions, and uncommon mutations. A galaxy of speakers, panelists, and faculty members will, in the coming almost 2 hours, take us through the entire gamut of what all has happened in the management of metastatic non-small cell lung cancer. I welcome you all to this academic feast, and let's learn and keep learning about management of metastatic non-small cell lung cancer, recent trends, advances, and newer paradigms. Thank you so much, and a warm welcome again to one and all.
Today's our first speaker, Dr. Bharat Vaswani. Sir, good evening, sir. And he is Senior Consultant Medical Oncologist, Yashoda Hospital, Secunderabad. And sir is going to speak on molecular biomarkers in lung cancer. Over to you, sir.
Yeah, you have to pardon me, actually, sore throat. So voice slightly, it is down. Can you see my slides?
Yes, sir.
I'll make it. Yeah, now is it visible?
It's visible. Just need to make, yes, it is full screen mode.
Wonderful. So let me thank Dr. Satya sir, whom I consider as my elder brother, for the kind invitation, and the ASTA people. I have been given a small topic. Actually, my stage is very well set by Dr. Satya sir. Now, if you think of a single cancer as a whole, which is that cancer where molecular biomarkers or molecular classification, or depending upon molecular or the genomic marker, we decide treatment. You can go through your entire oncology. And the most important thing is diagnosis and doing the test to find out whether there is a driver mutation or not. Clinically relevant, yes. First, we have a drug available. Now there are 10 targets, 8, which has been, when we call as ESMO, SCAT, category 1, 8. No cancer, it has 8 targets, and 2 are in category 2, what we say steps 2. And then you see lots and lots new targets are being discovered. So it is imperative, or it is mandatory for all. This is the most important thing, that once you have a diagnosis of non-small cell lung cancer, preferably non-squamous. Even in squamous, there are some targets which are positive. Or if you are a non-smoker, or if it is a mixed type like adenosquamous, it is mandatory to do this molecular testing. Now, how to do it, which is the best platform to do, it is what I am trying to tell you. Now, it is divided. My presentation has divided into biomarker testing, what are the evolution, and some key takeaways. Now, this is in short, 50% of patients with advanced non-small cell lung cancer have a driver mutation. Please remember, it is targetable with an FDA-approved agent or on a clinical trial. I'll go one step ahead and say that if you are a never smoker or a female, this level or this actionable mutation, this incidence or this percentage rises as high as 80 to 90%. So whenever you have a patient like this, it is mandatory to do a best platform that is available, because you all know that it changes the treatment paradigm of that patient. Now, chemotherapy versus a targetable mutation. Why you should think of it? So the most important thing is, when you use this targetable therapy based on the genomic driver mutation or the diagnosis, there is an improvement in the overall survival. This was a big retrospective study which showed that there is a gain of 7.2 months as a whole when you give or when you treat your non-small cell lung cancer patient with a driver mutation with the specific molecular drug that is available rather than only chemo. So it carries a overall survival advantage. What do our guidelines say? So if you have to remember, SCAD1, there are 8: EGFR, ALK-ROS, BRAF, MET exon 14, RET, NTRK. And this KRAS and exon 20, these both are in category 2. So if you have to remember, EGFR, ALK-ROS, BRAF, MET exon, RET, and NTRK. And KRAS, we have 2 targeted drugs now, sotorasib and adagrelib. So this is what NCCN suggests, that it is mandatory to do all these targets before you proceed for your treatment, and whatever NGS or platform that you are using should cover these 8. Look, you have some drugs which are available through compassionate program also. So it is always good to do these mutation tests. Now, the most important slide, which is the best platform? Still, we are using IHC and FISH for ALK and ROS. Definitely ROS, if IHC it is positive, we need to prove it by doing a FISH. But the most important thing is the other 2 things. For all fusion genes, please remember, DNA NGS is not the gold standard. RNA NGS is the gold standard. So if you have a patient who has ALK, ROS, RET, or NTRK, probably not diagnosed, but whenever you do a platform, please see that it should have your both DNA as well as RNA NGS. This is what the newer platform is all about, because RNA picks up nearly 5% more fusion abnormality as compared to DNA. Of course, for EGFR, if you say for mutations, insertion and deletion, DNA is the gold standard. IHC FISH, we still do it probably because the turnaround time is faster as compared to the other 2. Even PCR, you can say the same thing. Now, let me talk about evaluation of biomarkers. So, which tissue to choose? So, primary as well as metastatic, any of the 2 is good. Only thing is bone. Be careful, because of decalcification, there is a degradation of DNA. So, you may not have a correct report when you talk about bone as a thing. Now, this was what I am trying to talk about, the SCAT ESMO target, what do I say, clinical target for molecular things. So, that is, these are the most important things that it should cover. Apart from it, KRAS as well as exon 20 insertions for EGFR. You should, now what about liquid biopsy? Now there is always that debate that should I do a solid or a liquid biopsy? Please remember 2 things where liquid biopsy you don't have such a good de novo diagnosis and doing a molecular alteration. Probably I may discount the Nile study. So if you have a very good platform like a Garden platform, you can still have a diagnosis and de novo when you do on day 1, and a histopathological diagnosis. So sometimes in the due course of treatment, when there is a transformation to small cell type, one of the examples that might be, these are the 2 shortcomings when you use a liquid biopsy. So de novo on day 1, probably if you have a good platform, that is also taken care of. And during the course of the disease, sometimes if there is a small cell transformation, these are the 2 limitations of doing a liquid biopsy. The most important application of liquid biopsy is what we say monitoring the response to treatment or finding out a mutation variant during the course of the disease and changing accordingly. You can remember your ALK rearrangement or what. At that time, probably if there is a progression and when you have a facilities available, you can do your liquid biopsy. Liquid biopsy testing overcomes major challenges associated with tissue testing. You don't have to, it is a non-invasive method, and it can capture tumor heterogeneity and tumor changes over time. So probably more and more people are using it, except for the 2 limitations. I think so it is as good as a solid biopsy now. But please remember, you should have a very good platform when you do it. If you have to have like a foundation liquid we have, then we have a Garden platform. Now, some do's and don'ts, whether you can, when you can do a tumor tissue or a liquid biopsy. Now, in the few years, you'll see liquid biopsy probably will be as good, except for the 2 things that I told you. Now, which platform to use? So you have an immunohistochemistry, you have a polymerase chain reaction, and the most important is next generation sequencing. And that also is what we call as comprehensive genomic profiling. So a multi-gene targeting NGS, this is the most important thing. You have 2 types. You have a hotspot, what we say, which covers a limited number of genes, and you can have a CGP like foundation, which covers more than 300 genes. Now, what are the advantages of NGS? Now, the most important thing is it can pick up all known molecular alteration in a single test. This is most important. So this is probably the way to go, because previously there were a lot of people still doing a PCR because we had EGFR Alcross. Now, when you see now there are 10 targets available, and you don't have sufficient tissue for these 10 targets. So probably the best way is to do a what we say comprehensive genomic or a broad-based NGS panel. Only disadvantage of NGS is a turnaround time of around 2 weeks. So probably when you are in hurry, probably that is the only way where you can think of it. But for all purposes, now we are slowly moving towards a next generation platform. Let me start for a EGFR mutation. So formalin fixed, paraffin innervated fresh, all those tissues. If you see the discordance, probably least discordant when you use a primary or a metastatic tissue. So probably any of the two is good, provided that the cellularity is more than 10%. Now, recently we have seen EGFR, this mutation testing in early lung cancer. So probably we have a important or a magnificent results of ADAURA, and so that is why this is mandatory for all people to test for this mutation. In fact, by next, you see, 6 months to 1 year, even ALK might become necessary. We have a trial, probably the results will be out towards the end of this year about ELENA study, that was alectinib study. Should I use PCR or NGS? So the basic disadvantage, you can still use it in exon 19 and deletion 21, but for exon 20 insertion, definitely NGS is better than PCR, because probably 48.6% of EGFR identified are missed by PCR. So that is, again, you can still use your PCR, but for exon 20 insertion detection, probably this is less sensitive as compared to your NGS. What for ALK? We used to do IHC, probably again, very sensitive, but again, you need to do it alone. False positive rate is only 1% with FISH, but probably in future, again, you should start using your NGS even for ALK, because in future, you will see that variants are more important, because variant 1 chryso may not work as well as alectinic, and similarly in variant 3. So probably in future, the entire paradigm might be based on which variant you are diagnosing, and probably alectinic works everywhere, but chryso doesn't work in variant 1 so well. So probably NGS will pick up the variant and it will be advantageous. And so again, as important point, DNA or RNA. So for all fusion, if possible, do a RNA NGS. Again, Ross rearrangement, IHC definitely is there, but again, not like ALK where IHC is good enough. If you have IHC positive in Ross, it has to be substantiated with FISH, because FISH with IHC only doesn't carry any meaning. NGS, again, as sensitive and as specific, and it can detect novel translocation partners. Now, let us talk about KRAS. Again, this is mutations, if you remember. So DNA NGS is the most important thing. Probably the most common mutation, and the drug which is available, sotorasib, 6 months PFS, a good disease control rate of 80%. So probably no second thought, it is NGS only. BRAF. Again, you have 3, IHC, you have a PCR, but again, you have a NGS, and probably more than 50% are V600E. NGS is a way to go. So you don't have to remember. I'll be repeating on it. Whenever you have a positive, if you have a targetable drug available, go ahead and give it, because the PFS is nearly 10 to 11 months with the OS of 18 months, which is better than a chemotherapy. This is something that I have recently, like 6 months with the availability of RNA, lots and lots of patients are getting diagnosed with c-MET exon 14 skipping mutation. In fact, it is 20 to 30% of sarcomatoid. So if you have a sarcomatoid variant of anything, please rule out your MET amplification and c-MET exon 14 skip mutation. Again, increase sensitivity with RNA NGS. Methods, you know, but again, the take-home message remains the same. Similar with RET. In fact, RET, the responses with the new drug, pralsetinib and Selpa, is as good as 80%, 18 months of PFS. Again, being a fusion, RNA NGS is definitely better. If you have with it, that is the gold standard. Now, majority of RET fusion can be detected by DNA, but increased sensitivity is RNA. Of course, you can use the other, but probably nowadays most of us are not using. The last but not the least, this is again, probably again being a fusion, RNA is the best way to do it. We still continue to do IHC, but I think so probably most of us have evolved now and have moved away to do a CGP, which is comprehensive genomic profiling. So PCR for some, but probably because of the tissue, it is always good to go to a NGS to do all your testing. With increasing target tissue, tissue is always an issue, what we say. The last but not HER2 new mutations. Probably, please remember, these are most on exon 20. So you have two things. You have EGFR exon 20 insertion and you have HER2 new exon 20 frame insertion. There are some drugs which was good in HER2 new mutation rather than exon 20. Poziotinib, it is better for HER2 new mutation rather than a exon 20. Mobocertinib and amivantamab, these are better for EGFR exon 20 insertion. So probably this is also as important, not as less likely you thought. 3 to 5% of all non-small cell adenocarcinoma, mostly exon 20 insertion. Again, the best way is, and when I told it is insertion or RNA, I beg your pardon, DNA NGS. So in nutshell, you have multiple new targets, you have multiple targets, and mostly all the drugs are available on either normally or on a compassionate basis. So mandatory, think of doing a broad as profile and as sensitive as profile. PD-L1 expression. What we know about PD-L1 is it is interchangeable, except for SP142. As per as blueprint study, 22C3, 263 and 28-8, you can interchange it. Probably it is good enough as the concurrence. And that is what it is all about. So PD-L1, shown current marker, imperfect, TNB. One a take-home message. When you should think of doing a TMB, if you are giving a IO, once you give IO plus chemo, TMB may not hold such importance. But if you look into all your studies of Derma, Tremi, or Ipinivo, Checkmate 227, when you think of doing a TMB or when it is the IO study, the moment you give IO with chemo, probably PD-L1 is a better way to see whether these drugs works well in or not. MSI, not much relevant. LEG3 still in development. This is in nutshell the overall targets that I have told. 8 in category 1, 2 in category 2 or no. And that is why, and we have drugs available. The best way is NGS. So if I have to conclude, biomarker testing in non-small cell lung cancer has evolved from single gene to multiplex. If people still say that they are doing a PCR, probably that is not the right way. If you are lucky enough to have the 3 of the common mutation, but you may miss out the other mutation and patient may afford or may get it on compassionate basis. Multidisciplinary meeting help in better understanding of the sample and test requirement. Importantly, sample should have an adequate tumor content, at least 10% cellularity. The turnaround time is 2 weeks or what we call as 10 working days. And in the future or now also high throughput platforms such as NGS I think so, should be used to screen several genes at a time to provide within the estimate turnaround time. I thank you all for a patient hearing. Probably most of us have evolved, but it is high time people who are not doing it should start doing it. Cost also has come down to 8 to 10,000 for a 52 gene panel. I thank you all for a patient hearing.
Thank you for the wonderful presentation and always finishing well on time. Thank you so much, sir. And next, I would like to invite Dr. Pawan Raghav Reddy, who is Consultant Medical Oncologist, SCG Cure Cancer Center, Vijayawada. And he's going to speak on role of bevacizumab in lung cancer. Over to you, sir.
I hope my slides are visible. Yeah. What about now?
No, not now.
Yeah.
Yes, sir.
At the outset, I would like to thank you, AstraZeneca and Dattatreya sir, for giving me this wonderful opportunity. So without any further delay, let me go into my topic. I'm going to talk about the role of bevacizumab in advanced non-squamous and mNSCLC. So basically, just now, Dr. Bharat sir had given a wonderful talk regarding all how we go about, testing for targeted therapies. So as he has rightly mentioned, more than about a 50% of stage 4 NSCLC patients have biomarkers like EGFR and ALK, which can be targeted. And the treatment landscape for stage 4 NSCLC has greatly expanded in the past 1.5 decade, thanks to all these biomarker-driven targeted therapies and immunotherapies. So if we go back to 2016, we see the introduction of bevacizumab. That's the year when bevacizumab got the FDA approval for treatment in advanced NSCLC. So briefly, if we go about how we approach a case of advanced NSCLC without an actionable biomarker. So we first of all, we see if the patient has got a good performance status or not. And if yes, then we go ahead and see the histology of the patient, whether it's a squamous histology or a non-squamous histology. Say the patient has got a non-squamous histology, then we see whether the patient is an ideal candidate for, one, immunotherapy, and two, bevacizumab. And if so, if the patient is eligible for bevacizumab, we have all the combinations of IO and bevacizumab along with chemotherapy. A brief outline of how exactly VEGF, drives tumor survival. VEGF acts upon the VEGF receptor, which in turn, is a part of the PIK3, AKT, and mTOR pathways, as well as the RAS, RAF, MEK, and ERK pathways, which in turn are very crucial for cell cycle activation and survival. So if we go back to the late 90s, we had got a lot of preclinical data, which threw some light on the importance of, VEGF levels and microvessel density on the survival of NSCLC lung cancer patients. So these two graphs, they clearly show that if the patient's tumor has got high levels of microvessel density as well as high expression of VEGF, then usually they do worse. Fast forward to 2006. This is a landmark paper published in NEJM, the ECOG 4599 study, which looked at a combination of paclitaxel alone or with bevacizumab for advanced NSCLC. So basically, about 800 patients were randomized to receive either paclitaxel or to receive paclitaxel and bevacizumab, and then they were followed up. So clearly, it showed a clear-cut OS benefit of at least 2 months, and similarly, again, PFS benefit of nearly 2 months. And with this, this benefit was seen in all the subgroups as evidenced by this forest plot. And the adverse effects, which were always a concern with bevacizumab, and especially the bleeding events. So if you look at this percentages carefully, all the bleeding events in the control arm without bevacizumab was about 0.7%, and they were about 4.4% in the paclitaxel and bev group. And if you look at the grade 3 and grade 4 and grade 5 bleeding episodes, they were around 1 to 2%. So this was kind of acceptable toxicity. And based on this landmark paper, bevacizumab was given FDA approval in 2006 in combination with chemotherapy for advanced non-squamous NSCLC. Fast forward to 2018. Here is one more landmark trial, the IM-Power 150, which looked at the combination of atezolizumab with bevacizumab for the first-line treatment of metastatic non-squamous NSCLC. So briefly, the design here, three groups. First group had paclitaxel and atezolizumab. The other group had paclitaxel bevacizumab. And while the main, the control group that we would say had a quadruplet therapy, ABCP, atezolizumab, bevacizumab, carbo, and pacli, followed by either maintenance of atezolizumab, bevacizumab, or a combination of both. So here, clear-cut OS benefit. There were two co-primary endpoints, PFS and OS. Clearly, both the co-primary endpoints were met with reasonable toxicity. And then this forest plot shows that almost all the subgroups, irrespective of PD-L1 expression, the bulk of metastatic disease, and in fact, even a few patients with EGFR and ALK positivity also derived good benefit from this combination of therapy. So based on this particular trial, the combination of ABCP received its FDA approval in 2018. Further, the role of bevacizumab is very much there in maintenance, as we all know that for lung. Two landmark trials, Point Break and Avaparil. I would briefly go through this. This is the Point Break trial, which is a phase 3 trial, which looked at a combination of PEM carbobevacizumab versus pacli carbobevacizumab, followed by bevacizumab maintenance. So here the PFS showed a slight benefit towards the PEM carbo and bev group as compared to the pacli carbo bev group, and OS was almost similar. The point to be taken from this particular trial was that toxicity. It was very clear from this trial that the combination of PEM carbo and bev was much better tolerated compared to pacli carbo and bev. Next comes the Avaparil trial. Again, this is a phase 3 trial. Patients received 4 cycles of PEM cisplatin bevacizumab and followed by maintenance of either bevacizumab alone or a combination of bevacizumab and pemetrexate. So these are all the baseline characteristics. And here again, clearly a drastic difference in PFS, which was clinically and statistically significant. OS was more or less the same. So here to be exact, these are the advantage for PFS and OS over here. The OS benefit was not statistically significant. So based on these two trials, we have got a very well established role of bevacizumab for maintenance. And then we also looked at combining bevacizumab with EGFR TKS. So dual EGFR and VEGF pathway inhibition may improve the clinical outcomes in EGFR positive advanced NSCLC because of the crosstalk between and the inhibition of both the VEGF and EGFR signaling pathways. So this is the NEJ trial, which was basically a randomized phase 3 trial that took place across 69 centers in Japan. The trial compared erlotinib 150 mg per day versus erlotinib and bevacizumab 15 mg per kg, and the patients were followed up till progression. Again, very impressive PFS benefit here, 16.9 months versus 13 months, clear-cut PFS benefit in this particular trial. So these are all the data which look at, a combination of EGFR and VEGF in EGFR positive advanced NSCLC. The latest one being the relay trial, which actually looked with the combination of erlotinib and ramucirumab. So based on all this data, NCCN recommends that the combination of ABCP is a category 1 recommendation for first line or advanced metastatic NSCLC, non-squamous NSCLC. And if there are contraindications for immunotherapy, again the combinations of bevacizumab with conventional chemotherapy such as your carbopaclia or your carbopem or cisplatin-pem, these are all preferred category 1 indications. Coming to maintenance, again here we can see bevacizumab and a combination of bevacizumab and atezolizumab being category 1 recommendations for maintenance therapy in lung cancer. And these are the recommendations, and which clearly mentioned again the combination of erlotinib and bevacizumab for advanced EGFR positive NSCLC. So to conclude, bevacizumab is a tried and tested molecule in oncology. We are all very familiar thanks to its long duration in our therapeutic choices. And then it definitely has a role in advanced NSCLC based on all the data that we have seen through. And it is approved in combination with all three, meaning it is approved in combination with chemotherapy, with immunotherapy, and even with EGFR TKS. And probably it has a synergistic effect when combined with immunotherapy. So I would like to conclude with this. Thanks for the patient hearing.
Thank you, sir. Thank you so much for the wonderful presentation. And next, we move on to our next speaker of today, Dr. Sharat Chandra, who is consultant medical and hemato-oncology, European board certified medical oncologist at ECMO Medicover Hospital, Hyderabad. And he's going to speak on recent advances in the treatment of EGFR mNSCLC. Over to you, sir. So you are muted.
Sorry. Good evening, everybody. Firstly, I would like to thank AstraZeneca and Dr. Satya Dattatreya sir for providing me this opportunity to talk on recent advances in EGFR mutant NSCLC. So I'll just start sharing my screen. So is the screen visible? Yeah. So the topic given to me is the recent advances in the treatment of EGFR mutant NSCLC. So to begin with, the learning objectives would be to discuss the treatment burden and treatment options of NSCLC as per just a second. Yeah. So discuss the burden and treatment strategies for NSCLC as per NCCN and understand the emerging first-line treatment landscape of treatment targeted therapy in EGFR mutation positive. Evaluate the efficacy and safety data of different first-line treatment options which are available for EGFR mutation positive NSCLC. And finally, discuss the role of osimertinib for the first-line treatment options with the most common targeted mutations. So the first thing, burden and the treatment strategies for NSCLC. As we can see, as per the 2020 Globocon data, lung cancer is the second most commonly diagnosed cancer, with 1 in 10 cancers globally diagnosed and 1 in 5 global deaths recorded. So as you can see, the median OS for metastatic NSCLC was 4 to 5 months with supportive care alone, and about 6% 5-year survival when we used historic cytotoxic therapy. So when we used the targeted and immunotherapies, the 5-year survival jumped from 6% to a range of 15 to 50%. So an overview of the EGFR mutation positive NSCLC, as you can see, in Asians, around 40% of them are positive for EGFR mutation, non-Asians about 20%. In Indians, the frequency ranges anywhere between 20 to 25%. So EGFR mutations are located in the tyrosine kinase domain and result in increased tyrosine kinase activity, leading to continued cell proliferation. So the most common EGFR mutations, as you can see, about 52% were exon 19 deletions, and close to 26 to 27% in exon 21 being L858R point mutations, and the rest of the other mutations are exon 20 close to 15%, and other mutations ranging between 6 to 7%. So if you can see the data about first generation and second generation and the third generation TKS, as you can see, Geftinib trials were the initial, then came erlotinib, then came afatinib, and parallelly dacomatinib and osimertinib trials. So first line treatment is their best option. We'll just go through which are the treatment goals in EGFR mutation positive. These are the 7 different different parameters which you consider when you're opting for a treatment for first line EGFR mutation positive patient. So you need longer PFS, you need higher objective response rate and improved overall survival, reduced CNS mets. As you know, more than 50% of our patients end up in CNS mets, good safety profile and tolerable toxicity, and improved quality of life, and also a prolonged time to first subsequent therapy, which will all add up to the overall survival. So we'll touch upon all this with a special regard to osimertinib today. So the first things first, when you compare the different first and second generation and the third generation trials available, so the Lux Lung, which came first, afatinib showed a PFS of about 11 months, comparing to 10.9 months PFS from Geftinib. But you can see the separation only happened at 11 months. So in Archer also, the separation happened at about 6 months. But when coming to the Flora trial, you can see that the curves separated immediately, indicating that there is a lower frequency of early resistance to osimertinib, leading to a longer PFS. So when coming to different mutation subgroups, as expected, exon 19 deletions would always fare better when compared to L858R. So across the different trials, if you can see osimertinib exon 19 deletion, the PFS was close to 21 months, and L858R also close to around 15 months, which is the highest among the different TKs which are available. So then coming to higher objective response rates, close to about 70 to 80% of objective response rates are achieved in each of the different TKI trials, but the highest numerical response rate is definitely achieved by osimertinib, and a median duration of response is also the highest in osimertinib, which is close to 17 months when compared to the other afatinib and the dacomatinib duration of responses. So a longer PFS and higher ORR with osimertinib when compared to the other two. So when coming to the overall survival, this is very important here because the meaningful overall survival so far is achieved only in the trial with osimertinib Flora, because numerically, even though the dacomatinib trial achieved a statistically significant OS when compared to Geftinib, but then the conduction of the trial was a little different, because it was a hierarchical design where only if your PFS was statistically significant, you go on to do the statistical significance for the next, which is overall response rates, and then followed by the OS. but the trial ended at a non-statistical significance for overall response rates with dacometinib, and then they actually could not check the overall survival for dacometinib as per the statistical design. But as an ad hoc basis, the numerical statistical significance was as shown in the curve, which is about 34.1 months. This is the argument with the dacometinib. But when coming to the FLORA, the overall survival was close to about 38.6 months, which is definitely significant when compared to the comparator arm. So this was just what I was mentioning. The hierarchical statistical testing was as per this in Archer trial. So this was the contention with the overall survival which was presented with dacometinib. So then the CNS mets. CNS mets reduction is very important when we are considering the TK and EGFR mutant patients, because close to around 50 to 60% of our patients end up with a CNS met during the course of the disease. When you compare the different trials, Archer had actually excluded the CNS metastatic patients. FLORA had around 20%, and Lux Lung 7 had close to 16%. The highest number of PFS was actually achieved by osimertinib, as you can see in the picture depicted here. The highest CNS penetration with the representative PET images was achieved by osimertinib. So as you can see, CNS activity, PFS in CNS mets was close to 15.2 months, which was clinically meaningful. And then PFS in patients without CNS mets was also close to 19.1 months. So osimertinib demonstrated a superior PFS regardless of CNS disease activity. But when you compared a patient with CNS mets, you can also see the statistically significant benefit when almost a 53% risk reduction in CNS metastatic patients, which was achieved only with osimertinib. So then the consensus from the Canadian guidelines was the preferred first-line TK with the CNS mets was osimertinib as per this data. So then we'll discuss a little bit about safety profile and tolerable toxicity. So as you can see, if one has used all the three different TKs, you know, osimertinib is the one which is decently well tolerated when compared to the other two. Dacometinib, we will really have issues with rash and dosage reductions almost in every second or third patient. Even afatinib, the dose reductions are quite high, even in clinic and when compared to the data presented in the trials. So grade 3, more than grade 3 associated effects with osimertinib was close to 32%, but the most well-tolerated drug is definitely osimertinib. So the adverse events leading to dose reductions, as you can see, the most was with afatinib close to about 42%, dacometinib, as you can see, 38%, 28%. Although once you dose reduce, the dacometinib is actually well tolerated, but you actually would need dose reductions as per the data presented here. So the prescribing information of dacometinib by the guidelines or the prescribing information was about dose reductions of 66% was reported. So the median time to first dose reduction was about 3 months. So then coming to quality of life improvement, which is also very important when you treat a metastatic mNSCLC EGFR mutant case. So as you can see in the Lux Lung study, they were not actually very meaningful reported outcomes. Almost the quality of lives were similar between afatinib and geftinib. Actually, quality of life improvements was very meaningful when checked in the osimertinib trial when compared to the other TK as the data presented here. So coming to Archer 1050, also the quality of life improved more significantly with geftinib when compared to dacometinib. The reason being maybe the dose reductions. Overall global quality of life was improved from baseline in osimertinib when compared to the other TKS as presented here. So then coming to time to first subsequent therapy. This is a beautiful slide presented here. As you can see, in the comparator arm, almost close to 47% of the patients went on to use osimertinib in the first subsequent therapy. Even with a large crossover, like overall survival was clinically meaningful as presented before. So the time to first and second subsequent therapies are also presented here in osimertinib in the FLORA trial. 25.5 months was the time to first subsequent therapy, and 31 months was the time to second subsequent therapy, which is very meaningful in terms of clinical practice. So then after discussing all this, is sequencing the right strategy for EGFR mutant? We'll just discuss what would happen if we sequence or what would happen when we use osimertinib upfront. So the resistance patterns need to be known to understand whether it would be better to sequence or use osimertinib upfront. So when you have a first progression, almost 57%, the reason being T790M mutation and other different resistance mechanisms.
Presentation in 2 minutes.
As you can see, almost 3 out of 10 EGFR mutated patients only go on to use osimertinib when you actually sequence, and almost 70% of the patients are missed out. So you are missing out on the best option when you actually sequence. So then osimertinib is recommended for the treatment of choice as per the flow chart presented here in common mutations of exon 19 and L858R. So there, then you can see that 2021 guideline where the initial first line therapy preferred was osimertinib when compared to the other TKS. And then this is one flow chart showing when there is a progression, you could also use local therapies and then continue osimertinib. So to conclude, osimertinib is the only EGFR TKI which has demonstrated the clinically and statistically significant improvement in overall survival, and is well tolerated at 80 mg. The dose reductions were very minimal, and clinically meaningful overall survival benefit and reduction in CNS mets would make osimertinib as the first line choice. So thank you.
And next, as we move on, I would like to thank AstraZeneca. And next coming up is the case-based panel discussion. The topic is advanced EGFR mNSCLC. And to moderate the panel, I would like to invite Dr. Vamshi Krishna, who is consultant medical oncologist and HOD director, AIG Hospital, Hyderabad. Over to you, sir, to invite your panelist. So the panelists on board are Dr. Sharat Chandra, Dr. I think Pavan Raghav Reddy is there. Dr. Vindhyavasini won't be there, sir, and Dr. Mahati won't be able to join. Rest all panelists are there, so you can invite them, sir.
Were you telling me, am I supposed to
Yes,
invite?
sir.
Oh,
Yes,
okay,
sir, please
okay.
invite. I'm just informing you that these doctors won't be there because
Sure,
of
no
some
problem.
emergencies.
Okay, no problem. So, good evening, everyone, and welcome to this discussion. I invite the panelists. I guess Dr. Sharat is there. I just saw him. Dr. Mahati is not joining. Dr. Pavan, are you there? Pavan Reddy from Vijayawada. Dr. Pavan, are you there? Can't hear you. Okay. Dr. Kripa? Dr. Kripa Bajaj, are you there?
Sir, she's joining in a minute.
Okay. And we have Dr. Rachna. I can see that. Dr. Vindhya has not joined. Dr. Satya Srinivas? Dr. Srinivas? Not there. So I guess it's only Rachna and Sharath. Dr. Bharat Vaswani, are you there? He's joined, but I'm not sure if he's there. Dr. Bharat? Okay, so Dr. Bharat is not there. So Dr. Sharath, you, Rachna, and me, I think that's what we are going to be discussing. And if Kripa joins us, then we'll have Kripa as well with us. I guess that's what it is with these meetings. Fair enough. So next slide, let's just start off with this case-based panel discussion on EGFR mutant NSCLC. Case, not my case. This is given by Astra. So 65-year-old male, non-smoker, cough, chest pain, 5.5 centimeter, nodes, pleural thickening, effusion. So essentially a metastatic disease. Biopsy coming as adeno-CA, TTF1, napsin-A positive, with PD-L1 more than 95%, and EGFR exon 19. Okay, it's pretty simple, straightforward case, routine run-of-the-mill case. So let's start off with this question, Dr. Sharath. Which are the routine tests that you do in your practice?
Markers these days we're asking for lung panel whole next generation sequencing, which would include all the EGFR, all cross, RET-MET, NTRK, BRAF, PD-L1 and everything. Sir.
Everything means 365 genes, 200 genes, 12 genes,
No,
because
sir,
NTRK is not
cancer.
included. NTRK is usually not included in that because that's an RNA fusion type. It's not included in the typical 12 gene, which is done by the Kupan, so-called Kupan testing.
Mostly we are using the Kupan.
You're using the Kupan testing.
In-house we
not
don't
done.
have.
All right.
Yes, sir,
that's fine. That's, I think, mostly what we are doing, including myself. That's what I do. Rachna, how do you do it?
So we are also using the coupons for doing the limited NGS panel, the 12 gene panel.
Have you started doing PD-L1 in-house in your hospital?
Yes, sir. We do have PD-L1 in-house, but presently we are sending the entire tissue to the same lab where we are getting the NGS panel done.
So this question that is asked is mainly, I guess, for other labs where they have their in-house PD-L1. So the PD-L1 report, some people do get it early. And the question really is, what do you do if you get your PD-L1 in 2 days and the NGS in 15 days? Because that's, I guess, the question which needs to be answered. In our panel, I think nobody is there who is doing like that. So this question is moot for us. But in that scenario, let's assume that you get your PD-L1 faster vis-a-vis the EGFR and NGS report. Would you really act on that PD-L1, Dr. Sharath?
No, sir, I would wait for the entire molecular marker panel to come. Only if all the other molecular mutations are negative, then I would consider this PD-L1 as significant and then try and counsel the patient about immunotherapy, sir.
What's your TAT for getting this NGS on an average? How many days are you taking to get it? Sharath? Dr. Sharath, can I hear? Rachna, can you hear me?
Yes, sir.
Yeah, so same question to you. What is the time that it takes for your NGS report to come?
At least 10 days, sir. NGS report we are getting at 10 days. PD-L1 we are getting a bit early with the same coupon also. The PD-L1 report is coming a bit early because of the IHC testing which they are doing. So yes, we do get the PD-L1 early, but we are not acting on it immediately. We are waiting for it to be a driver negative to act on the PD-L1 with immunotherapy.
Okay, so I think this for me actually 10 days also is a pretty early time. I would say I usually get in 15 days, so that's how it is. So Dr. Sharath, he has joined us or he's also left. So I think it's Dr. Rachna and me here holding the fort because I can't see Kripa joining us. So it's only you and me, Dr. Rachna. Great. Okay. So what do we do in a case when, for example, we don't have we have a patient who is a little symptomatic? Are you still seeing that scenario where you are forced to start your chemo while waiting for the result, or are you able to now wait for your results? What do you normally do?
No, sir. Around 30 to 40% of the patients, we are starting chemotherapy, sir.
And the remaining 50 to 60, are you starting off on a TKI waiting for the results to come?
Well, yes, sir. We are waiting for the results. If they are asymptomatic or if they're just pleural effusion, which after draining is becoming asymptomatic, we are waiting for the TKI report, I mean the NGS report. If the patient is symptomatic, we are sending the sample for testing, but we are starting off with chemotherapy. At least one cycle of chemotherapy we are giving.
So either chemo or watch and wait, if I understood you correctly. Yes. That's how you're doing. Fair enough. I think there's again a big discussion and you're expected to get fast. So in fact, when we discuss with other colleagues in other cities, there are centers which are doing EGFR in-house by PCR, getting the result in 3-4 days, ALK in 1 day, and then the PD-L1 in 2 days, and then they say, okay, then we'd wait. So, I mean, these are centers where I don't practice in my center, also the same challenge we are having. So,
yes, sir. We don't get such fast results to act
I
immediately.
wish we could get that as well. So
Yes,
I think,
yes.
Dr. Sharath, we were discussing what to do when the patient is symptomatic and how many percentage of our patients end up getting some chemotherapy before they can, actually start off the EGFR directed or whatever directed therapy. How many percentage wise approximately?
So definitely, my strategy would be that only, sir. If the patient is symptomatic, I would start off with maybe a PEM-carbo combination, and then by the time we are heading to the second cycle, this molecular marker mutation would be ready, and then we can decide whether to complete the 4 cycles or then start off the mutation-based therapy immediately, sir.
So how many percentage wise? I mean, in my practice, I would say less than 20% I'm actually starting chemo. I wait for the results and then I start. But what's your practice?
If you're symptomatic was the discussion.
Okay, in all, okay, not just symptomatic. Okay, let's say in all, as a whole.
At least I would use that strategy in about 25% of the cases.
25% of cases.
Yes.
I think that's a fair enough number. The other thing which we really need to remember is, the tissue is always inadequate sometimes, especially the fusion only. And we are forced to, do either a liquid biopsy or a repeat biopsy. So what's your strategy generally? Do you send for a repeat biopsy or are you just happy to do a liquid biopsy? Because I've had 3 patients consecutively in the last 3 patients I have seen where the tissue is insufficient, and I was forced to actually utilize a liquid biopsy for those patients. What's been your experience?
If the tissue is inadequate or when we are not able to, I had one instance where the patient was not ready for a tissue biopsy. Then I had actually sent a liquid biopsy, and thankfully that picked up an EGFR mutant for me. But then if the tissue is an issue, then liquid biopsy is the way to go, at least for me, sir. I wouldn't venture on a rebiopsy unless the patient is convinced. Only if the liquid biopsy comes negative, then I would start this discussion of a rebiopsy, because I would want that to be confirmed on a tissue again.
Okay. Dr. Rachna, your thoughts on this? How many do you get? Again, I mean, for you, it's probably even more difficult than for us. We wait for a few days and then the tissue report comes at tissue inadequate. But somehow the tissue inadequate report also takes 1 week to be told to us, where it should be told us in a day or 2.
Yes, sir. So yes, so we are also, as you told, we are also getting a lot of patients reports as insufficient tissue for the NGS testing. So if the sample which you have sent is for a pleural fluid cell block with a good enough tissue, we are trying to redo the cell block and send it. If it is some difficult biopsies, we are asking the patients to get the liquid biopsy done, but most of our patients are generally not affordable to go with the liquid biopsy testing. So we are at least starting with the chemotherapy for such patients and rebiopsying at least on the progression.
Okay, rebiopsying on progression. That's one way of doing it. So probably you'll be just sending this one and then rebiopsying. That's also one way of managing, I guess. So great. So again, the question is for EGFR, are you looking now at which EGFR patient has, or are we just saying all EGFRs are stable? So that's my next question really. That are we talking of EGFR as one entity, or is it now separate entities? Dr. Sharath, when you see the report, you get a mutation in EGFR, you're happy, or you want to again check which particular EGFR? Would you treat exon 19 and L858R differently?
Definitely, exon 19 and L858R, my option would be some, depending on the affordability, that anywhere between first and second and third generation.
Okay, let's forget about the affordability part. Affordability is okay. We all understand the problem. If affordability we discuss, 80% will go on single agent Jeffy. We'll discuss that issue separately, but in general, I'm asking. Now, assuming this is an exon 19 deletion, what would you want
till the FLORA data, which showed L858R in Asian population, was a little bit dicey.
So I'm talking now on exon 19. Let's
exon 19 definitely osimertinib, sir. No
only
question.
Osimertinib, but why? Because of the OS data?
Definitely, yes, sir. Because of the OS data and all the other options which we just discussed in the previous.
So Erlo-Bev and Erlo-Ramu, they give you actually a higher PFS benefit as compared to the Osimertinib. And that's one reasoning. Erlo-Ramu gives you around 19 months, Ossi is giving you 18 months. So would you still be okay with Osimertinib? Because again, look at the OS data with, say, the Erlo-Bev, which is around 53 to 54 months. Not significant, but still 53 to 54 months.
Numerically
yes,
high, yes, sir.
Yes.
I would still go with.
You would
I would
still
still
go
go
with
with osimertinib and
Okay.
then keep this option for a second line, definitely, yes, sir. Because that
following
would actually
osimertinib, you
prevent.
would like to add erlotinib and bevacizumab. Okay, that's a very interesting way of doing things. I'm not sure we have any data to support that actually. That post osimertinib, whether you can use erlotinib except or possibly in a C797, but otherwise I'm not sure we can do that. Rachna, what's your thoughts on this? Would you still stick out your neck and say, okay, exon 19 or OS data, so we'll do?
Yes, sir. I would go with osimertinib because of the tolerance issues also. We have a whatever Flora trial data or any other studies which have used osimertinib, the tolerance is very good. If you are speaking about the combination with chemotherapy or erlotinib plus bevacizumab and ramucirumab, the toxicity is on the higher end compared to the osimertinib. So not only the OS, but also the tolerance and the quality of life the patient has with osimertinib. I would prefer osimertinib in the first line for exon 19 deletion.
Excellent. And I think one thing we are all now convinced that second generation, that discussion is over. I don't think any one of us would want to use either second generation or a first generation alone. Is that wantedly? Let's put it as wantedly. Is that an accurate?
Also joined us.
Dr. Vindhya has joined. Okay, Dr. Vindhya, welcome. So
Thank
question we were asking was about the first line and how to differentiate exon 19 versus, exon L858R and so on. So again, options for first line exon 19, what would you want to use?
I would go with osimertinib. If patient is not affordable, then chemo plus geftinib.
Okay. So again, this is the next thing which I really want to ask both the other panelists as well. Supposing we have a situation where they're non-affordable, Sharad did say that. So in that situation, would you go Jeffy alone or would you go Jeffy with chemo?
I had tried Jeff plus chemo in 2 patients, sir. I am very happy with the results, sir.
Okay, excellent. Rachna?
So young fit patients, I would try geftinib plus chemotherapy.
Okay. Okay. Generally, most patients, is it reasonably okay for them to, the tolerance wise, the combination?
Yes, sir. We have given for 2 or 3 patients and they are tolerating well, geftinib plus chemotherapy. But we have a strict criteria of using it less than 40-45 years, not more than that.
Okay, so, less than 45. Okay,
yes.
That's interesting. Okay, because again, this is a different. Yeah, very good. Good.
Any particular reason to restrict to that age group?
Mainly for the tolerance reasons, ma'am. Nothing else. Just the older age group, we are not. Don't want to try the combination of geftinib plus chemotherapy.
Even I had my reservations when I was beginning in my 65-year-old patient, but then she tolerated it better than what I expected. So definitely.
Yeah, I think that's been the theme, at least from the PMH gang, that the TMH group is using this and they feel that this is a reasonably good combo. And at least I think in those patients who cannot afford osimertinib, I would say Jeffy plus chemo remains a better option rather than only geftinib or only a thing. So having said that, I have hardly used it in 1 or 2 patients myself. I have not used it in too many patients. The tendency is to just put them on Jeffy and leave them, and they can come once in 3 months and stuff like that. So this was about exon 19. What about L858R? What's your thoughts on L858R? Now here the situation is different. Would you want to include a dacomitinib instead of OSI, or is OSI the better option? How do we look at it? Dr. Sharath?
I had tried dacomitinib in 1 L858R only for the reason that he was not affording osimertinib. That was the reason. But then after the data presented at the Flora OS, in the OSMO, where they had presented the data and the Asians and L858R subset actually did not do good. I have my reservation, although they were just subset analysis, but overall definitely it benefited. But then that is one contention.
Okay. Dr. Vindhya, your thoughts on L858R? Would you still say it's okay, osimertinib is fine? Or would you want to use a Jeffy chemo or a Erlo-Bev? Erlo-Ramu again has an OS advantage. DACO has an OS advantage in that subset.
Yeah, either osimertinib or erlotinib plus ramucirumab.
Okay. Dr. Rachna?
So we are using osimertinib only, so most of the patients.
Okay.
Keeping the affordability aside, we are using osimertinib only for L858R.
Okay. I think
your take.
Yeah.
My take on dacomitinib.
So, my take on dacomitinib is if a patient comes with the L858R without brain mets, that is a scenario where I actually discuss dacomitinib. My enthusiasm for DACO is less because of toxicity. And frankly,
Yes.
I've used it 3-4 patients. The toxicity is significant. The one patient who has now been on 1 year of DACO is on 15 mg once a day. So, 45 to 30 to 15. So he's on 15 and he is doing well on that. But toxicity remains a concern for me. Erlo Ramu, the data looks very interesting. Again, for me, the whole idea of bringing the patient once in 3 weeks and that constant Erlo such a long time, I've never used it. So though the data looks interesting, and certainly it is something that I discuss, I think, like Rachna says, we end up using osimertinib. And again, the whole OS data based on a subset, logically, there is no reason why it has not really worked. So I guess I am kind of on the boat on this. If there are brain mets, there I have no doubt I usually use osimertinib. That's how I would do. So, I mean, that's how my practice is, that in brain mets, I kind of tend to use only osimertinib is the way I look at it. So that's how it is. So what about these other mutations that we see? Exon 20 insertion, what do we do? Dr. Vindhya, your thought on that. Exon 20 insertion, how common is it? The data says it's around 5 to 6%. I have to say, I don't see that high a percent.
I have seen in one patient, maybe 1 year back. Not that common.
Yeah, but it seems to be more common. The Tata data showed around 3 to 4%. And amivantamab has been used, is now available, though quite prohibitively
the second line, I believe.
It is approved in second line. The first line data has not yet come out. So that's exactly why I'm asking, what would you do if you get an exon 19, exon 20 insertion today? Chemo, great. And then wait for amivantamab in the second line. Rachna?
Yes, sir. Chemo first line and amivantamab in the second line.
Perfect. I think we are all sticking to guidelines here and we are not waiting for that trial. That trial apparently has been there in a lot of centers in India. It was there in Hyderabad as well, but never got a patient to put it in. What about the rarer mutations and the combination? So you have a combination of 2 EGFR or you have rarer mutations. What do you normally do in that, Dr. Sharath? Again, not a common scenario, but with NGS, you pick up more combinations. How do you manage that?
My experience is very little with that, sir. But given a patient maybe any TKA plus the other, sir, I'm not sure, sir, to be fair.
You're not
maybe
sure.
afatinib in some of the rarer mutations, especially if the
definitely
patient is not a fit candidate for chemotherapy.
Okay, fine. My experience with afatinib has been it's as bad as chemo, actually, in many cases. That is what I have been noticing. But fair enough. There is some data on osimertinib as well in the rarer mutations. So I think that's the other thing. A lot of data has been available on osimertinib in rarer mutations. So that's one thing people have been using. So again, this is where it is. This is what it is. So this is actually what I follow, since Sharath was asking. If it is EGFR positive, exon 19 deletion, no CNS mets, I usually stick with osimertinib. Erlobev is an option, but by and large, don't give it to many people. Chemogeftinib is an option where patient will not be affording osimertinib. When there are CNS mets, I try to push for osimertinib as much as possible. L858R, I discuss DACO, I discuss Erlo Ramu, I also discuss osimertinib. End of the day, possibly I end up giving them. When there are CNS mets, I give osimertinib. The idea is in this list, whichever does not have a question mark in front of it is the one which has a OS data, right? So this is the table. Wherever there's a question mark, there's no OS data. Erlo Ramu has not come up with its OS data till now. Erlo Bev, no OS advantage anywhere. Osimertinib did not have OS advantage in this L858R alone. But otherwise, multiple lines, you see, it seems to be osimertinib the winner. And I think by and large in first line, last 2 years, nothing much has shifted other than the exon 20, where possibly next year we are going to be getting the amivantamab data. So the interesting thing is about the PDL1, are we really looking at PDL1 in a EGFR? Are we even looking at immuno in a EGFR? Rachna, your thought. Any time in the practice, ABCP had come in, but are you even looking at immuno with a EGFR positive?
No, sir, unless if you have exhausted all the options and if the patient is also not tolerating chemotherapy in the 3rd or 4th line setting. Until then, we are not considering immunotherapy in a driver mutation positive mNSCLC.
Very good. Dr. Sharath?
They are not my patients, but then I have seen 3 instances where they have exhausted all the EGFR TKS, be it first generation and then the osimertinib, and then trying ABCP had given a PFS of 8 months in one, and 1.4 years the patient is still running, sir. I was very surprised. This is actually Dr. Senthil's patient, but then she's known to me. So post osimertinib, she's on ABCP and still going good at 1.4 years, sir.
Well, I think you should ask Dr. Sendil how many he has tried OBCP and then whether this is an outlier or this is a common thing happening. My own experience has not been as good. So few patients we have tried, but generally increase in 4 to 5 months. Dr. Vindhya?
No, I have no experience.
Okay. So again, I think the advantage in EGFR positive only IO is not there. Personally, I feel the ABCP gives benefit because of the chemo component, not because of the A component. That's my personal feeling. But that's what it is. The data says that there's no advantage for PD-L1 inhibitors in EGFR positive. That seems to be the thing. So just another case where essentially looking at an oligoprogression, where the patient has responded very well, but 1 or 2 lesions increase. So by and large, what do we do in such cases? Dr. Sharad, oligoprogression, would you just treat the oligomet and then go ahead, or do you change the whole treatment?
Sir, if the oligoprogressive sites could be addressed by a local therapy, then yes, sir.
Okay. That's not.
And then I would continue. I would continue the
same TK.
Same TK.
Okay. Any thought of doing a liquid biopsy at that point of time, or would you do a wait for some more time and then do at progression?
Doing it that point of time, I would be ready for the next progression, sir.
So you would prefer doing it at that point of time?
Yes, sir.
Okay, no problem. I'm just asking. I mean, I don't do it because I wait for the next and then send it, but fair enough. If a patient is progressing on Jeffy, I like to do a T790M at that point just to know that I have to shift to a OSI at some point of time. Rachna?
Yes, sir. If the progression in the is such a site that where we can do a biopsy, we would do a rebiopsy and see for T790M mutation if the patient is on first generation TKIs, or also if there is any histological transformations also. If the biopsy, it is not an accessible site like a skeletal lesion, then we would prefer going for a liquid biopsy. And as Dr. Sharath was saying, if the lesions are amenable for a local therapy, I would like to continue the systemic therapy and address the local, the oligoprogressive metastasis.
Dr. Vindhya, I think this is now by and large a standard approach. I think most of us are now comfortable with the SABR concept. We are happy to send our patients for SABR.
Yeah. So, and this patient had oligoprogression while on osimertinib, right?
I mean, example, it's just a case, but yeah, on this case, yes.
Any role on escalating dose escalation?
Dose escalation, my experience is there's hardly anything. This was at that point of time. Now we know that if it is progressing on osimertinib, you would prefer actually shifting to a second generation, to a next treatment based on the resistance pattern. That's possibly what we would do. If it's an oligoprogression, just saber it and continue, but at the same dose. Dose escalation is mostly for the leptomeningeal spread alone. For non-leptomeningeal, I don't think there's any data for increasing the dose in a routine basis. Rachna, any experience from your side?
Dr. Kripa Bajaj has joined.
Oh, okay. I think we're almost at the end of the meeting, actually. So, Kripa, welcome, Kripa, to the last part of the discussion. So, Rachna, any thoughts on this part that we're doubling the dose?
No, sir. I haven't tried the double dose in any of the patients.
Okay.
Even the leptomeningeal also, we haven't tried it.
Fair enough. So I think this, even NCCN recognizes now that you should actually consider local therapy before you do anything else. And that's what I think most of us would be doing. So again, this is one more case, which is essentially about a brain metastasis and when you would advise a SABR. So Dr. Kripa, we are discussing EGFR positive disease. We have gone through all the deletion 19 versus L858R and all that discussion. Most of us concluded that, OSI is remaining the first line of treatment. For CNS mets, how do you go about it? The patient is symptomatic, local therapy followed by systemic, or would you do it simultaneously, or would you give systemic first?
So symptomatic patient, like I do start with the local therapy first, sir. After a few days of gap, I do start. Initially, we clubbed it both together, but there's a lot of brain edema happened. There is some data coming that edema can increase when we combine systemic therapy and radiotherapy together. So later we started giving 5 days of gap post local therapy.
Okay. And brain-wise, what is preferred? It's an EGFR positive, so you'd still go with the whole brain, or you're happy with the SABR wherever feasible?
It depends on if it is single lesion, definitely yes, SABR. But it's multiple lesions, like most of the times I do go for WBRT.
Okay. Dr. Rachna, your thoughts on this? Now it's not the number, it's the volume, they say. So when you talk to radiation oncologists, up to 3 to 4 can be SABR'd if the total volume is adequate. So would you still go for a whole brain in case, it's an EGFR driven tumor?
Even if it is an EGFR driven tumor, if the limited brain metastasis, as you're saying, but the volume of the sufficient to go enough for SABR, we would like to go for that, sir, rather than going for the whole brain RT. If it are multiple brain metastasis, the option is only whole brain RT for asymptomatic CNS metastasis.
For asymptomatic, you would go for whole brain RT.
No, sir. Asymptomatic, we are not generally radiating,
right,
unless it is in the critical
That was the next
site.
question. That was my next question. So if it is an asymptomatic brain mets, would you and EGFR driven, would go with systemic and not with whole brain?
No,
absolutely. Dr. Vindhya, agreed on that?
Agree.
Okay, perfect. So I think this is what we were discussing. I think we have discussed most of the options. And the fact is that after so many years of just discussing all the data and all, we are pretty comfortable with the first line of EGFR at least. And I don't think we have much to discuss on further. So till we get further evidence and further discussion, I think we can call osimertinib still the king in at least the first line EGFR. So thank you everyone and thanks for joining in. Over to the organizer.
Thank you so much, sir, for the wonderful panel discussion. And next, as we move forward, again, I would like to thank AstraZeneca for sponsoring all the sessions. And I would like to invite now Dr. Vindhya Vasni, who is consultant medical oncologist, Omega Hospital, Banjara Hills, Hyderabad, for a talk on safety of EGFR TKIs, which one to choose. Over to you, ma'am.
Thank you, organizers, for giving me this opportunity. So I would be rushing through the various aspects of the EGFR TKIs, especially. Are my slides visible?
Ma'am, it is visible.
It is visible, doctor.
Yeah. So as safety in regards to osimertinib versus the other EGFR TKIs. So I will be, I'll skip these slides. So as we know, the diagnostic workup requires adequate tissue for subtyping molecular analysis. And patients with adenocarcinoma component should be tested for the driver mutations, either by where now the next generation sequencing is used to detect a broader array of these mutations. And when we look at the current metastatic and mNSCLC management, it is driven by the molecular testing, where the targeted therapy has changed the treatment paradigm and have become mainstay in the treatment of metastatic mNSCLC with oncogenic drivers and high PD-L1. So with the use of chemotherapy alone, which is based on histological subtype for chemotherapy, the survival is around 8 to 12 months, whereas with the in case of EGFR mutations with the FLORA data, the survival is significantly improved around 39 months. When we look at the various driver mutation landscape in adenocarcinoma of the lung, we see that EGFR sensitizing mutations constitute 17%, KRAS is 25%, ALK 7%, and other EGFR and MET, ROS, BRAF all constitute around 2 to 3% each. So when we look at the EGFR mutation, which results in sensitivity and resistance to the TKIs, they tend to cluster at exon 18 through 21 in the non-small cell lung cancer EGFR gene. So the exon 18 to 21 is in the tyrosine kinase domain, and around 46% of these mutations are seen in the exon 19, which is a deletion mutation. 37% are point mutations in exon 21, that is L858R. Around 4.1% are the T790M mutations in exon 20, and the mutations are the uncommon or rare mutations. So EGFR mutations, they are oncogenic drivers. They are detected in approximately 50% in Asian population, whereas their incidence is lesser in the Caucasian or the Western population. In India, the positivity rate is around 25 to 30%. With most common being exon 19 deletion and L858R point mutations in exon 21. And for patients who harbor these exon 19 deletions and L858R mutations, EGFR TKIs are the first line of treatment. And other mutations other than the exon 19 and L858R are considered uncommon mutations. So the comprehensive clinical trial program for EGFR TKIs in mNSCLC evolved after the important molecular discoveries in the early 2000. In 2009, with the IPASS study, which is the first randomized study to demonstrate significantly improved efficacy with first-line geftinib versus chemo in patients with EGFR mutated advanced NSCLC. The treatment paradigm has changed later on with the publication of other studies involving evaluating other EGFR TKIs, the second generation, and then later on the third generation. The FLORA trial in 2017, which demonstrated superior efficacy over standard of care, that is the first generation TKIs first-line treatment in advanced NSCLC, have changed the treatment of the EGFR mutated NSCLC. So when we have to consider choosing the first-line treatment option in EGFR mutated lung cancer patients, the treatment choice depends on the efficacy of the drug and also the safety. So in this regard, when we look at, especially when we look at the performance of these drugs in the brain metastasis patients, when we look at the afatinib, dacometinib, which are the second generation versus the osimertinib, we see that in patients in the FLORA trial, the two curves, that is the treatment curve and the control arm, they have separated earlier on, showing that though these are cross-trial comparisons, the efficacy of osimertinib is far superior to the second generation TKI. So early and sustained survival benefit shown by clear separation of the curves within 3 months and maintained throughout the follow-up. And head-to-head studies show second and third generation EGFR TKIs provide significantly longer PFS versus the first generation EGFR TKIs, as we see for erlotinib, afatinib, dacometinib, and osimertinib. But osimertinib, we see that when compared to the erlotinib or gefitinib, there is a definite improvement in the progression-free survival, which is highly significant with the hazard ratio of 0.46 when compared to the other molecules. That is the second generation TKIs. So PFS is a direct measure of the drug's benefit, and immediate separation of the Kaplan-Meier curves in the FLORA study has shown that osimertinib provided unprecedented improvement in the progression-free survival according to the FLORA trial. So that is about the efficacy. When we look at the safety profile, when we compare the different, the safety profile is different to the first and second generation TKIs, and osimertinib is designed to selectively target both EGFR sensitizing and the T790M resistance mutations, while sparing the wild type EGFR. When we look at the first generation TKIs, their clinical targets include the wild as well as the exon 19 deletion and L858R mutations. With even the second generation TKIs like afatinib and dacometinib have activity on the wild type EGFR, whereas osimertinib is restricted to the exon 19 deletion and L858R and T790M. And the bioavailability of the third generation osimertinib and dacometinib, which is the second generation, is definitely better than the first generation TKIs. And this difference could be explained because of their structural difference and also their reversibility, where the first generation TKIs are reversible, whereas the second and the third generation TKIs are irreversible. The second generation TKIs are pan or B inhibitors, whereas osimertinib is a selective EGFR inhibitor. And when we look at the blood-brain barrier crossing ability, osimertinib has significant blood-brain barrier crossing ability when compared to the first and second generation TKIs. And comparative selectivity of the first, second, and third generation TKIs to the EGFR mutated versus wild type versus T790M is shown in this graph. We can clearly see that first and second generation EGFR TKIs have high affinity to the wild type EGFR, making them more toxic compared to the third generation osimertinib. And when we look at the frequency and severity of the selected clinically relevant all causality adverse events, They vary between the different generations of TKI. In the first generation TKIs, we usually see rash. That is in geftinib and erlotinib. Rash is more common. And also transaminitis, which is commonly seen in the first generation TKIs. In the second generation TKIs, diarrhea, stomatitis are more common. Whereas osimertinib, the side effect profile, adverse event profile is relatively patient friendly, with the most ILD events being the most common or most relevant for osimertinib versus the other TKIs. Whereas when we look at the other adverse events like rash, diarrhea, nausea, stomatitis, or elevated liver enzymes, these are far less common in osimertinib. So second generation TKIs lead to a higher frequency of adverse events that are associated with the pan inhibition of ERB, such as rash and diarrhea, than the first and third generation. And EGFR TKI-induced rash and diarrhea are usually mild to moderate in severity, but their frequency as grade 3 or more events can vary among the TKIs. And it is higher among patients treated with afatinib and dacometinib compared with those treated with geftinib, and is the lowest with osimertinib. The frequency of grade 3 rash appears to be higher among patients treated with erlotinib than those treated with geftinib. This could be possibly attributed to the difference in the pharmacological properties between the two drugs. And when we have to compare the adverse events between dacometinib and osimertinib, though these are cross-trial comparisons, we can clearly see that the incidence of adverse events like diarrhea, which is 87% in the dacometinib arm versus 58% in the osimertinib arm. And when we look compare with the comparator arm, the incidence of diarrhea is definitely higher. And the incidence of other toxicities like stomatitis, dry skin, paronychia are all higher in dacometinib arm. Whereas when we look at the FLORA trial, the adverse event profile between the osimertinib and the comparator arm are similar, with no significant difference between osimertinib and the comparator. And adverse events of any grade were much higher with dacometinib as compared to the osimertinib. When we look at the tolerability profile, around 49% of patients in the afatinib group had adverse event more than grade 3. It was even more in the dacometinib trial, which was 63%, whereas only 34% of patients in the osimertinib trial had adverse events more than grade 3. And second generation TKIs have unfavorable tolerability profile. Grade 3 and above adverse events are much higher with dacometinib and afatinib. And same grade 3 and 4 adverse events with dacometinib were reported in 63% of patients in the Archer trial. And when we look at the adverse events leading to dose reduction, it was seen in 66% of the patients, whereas it was only seen in 2.9% of the patients in osimertinib trial. And adverse events leading to death was significantly higher, which was 10% in the dacometinib trial, whereas it was only 2% in the FLORA trial. Though these are cross-trial comparisons, still there is a significant difference. So when we look at the safety of the EGFR TKIs, as first-line treatment, second-generation TKIs lead to a higher frequency of adverse events that are associated with pan inhibition of ERB, such as rash and diarrhea, than the first or third generation. And adverse event severity does not lessen or cannot be managed, and the dose should be reduced. Dose adjustments are more frequent with second generation TKIs, requiring more close monitoring and frequent visits. Osimertinib is considered to be well tolerated at its recommended dose of 80. And the dose management scheme states that a 40 mg dose may be given under certain circumstances. So depending on the adverse event duration and severity, a dose modification of second generation TKI may be necessary to improve the tolerability. When we look at the afatinib trial, Adverse events leading to dose reductions were more frequent. It was seen in 52% of patients receiving afatinib versus 1.9% of patients on gefitinib. In the Archer trial, 66% of patients required dose reductions of dacometinib versus 8% with gefitinib. Whereas in the Flora trial, only 4% of patients required dose modification or dose reduction for osimertinib compared to 5% for the standard of care. So, the second generation TKIs, afatinib and dacometinib, have been shown to frequently cause adverse events that require a dose reduction. In the Lung 7, as I explained previously, 52% of the patients required dose reduction, and 66% in the Archer trial required dacometinib dose reduction to 30 mg, and another 27% had dose reduction to 15 mg. And the median time to first dose reduction for dacometinib was within 2.8 months, and less than 3 months. And these data suggest that dacometinib is often intolerable at the starting dose of 45 mg. Again, when we, this is a post hoc analysis on the effects of dose reduction.
In 1 minute.
Sure. Yeah. So dose reductions resulted in lower incidence and severity of adverse events, and the incidence is much higher compared to osimertinib. So these are the last trials. The quality of life, when we look at the quality of life, in the Archer study, it showed that the overall quality of life, it significantly improved from baseline in patients treated with gefitinib rather than dacometinib. But in the Flora trial, osimertinib showed consistent trend towards better improvement of the quality of life. Several parameters of the global quality of life significantly worsened with dacometinib, whereas the quality of life improved in the osimertinib group. So I would not be going in detail about these rash and their management. To summarize, the second generation TKIs are burdened by the toxic profile, adverse events leading to dose reductions, 66 versus the 2.9%, and grade 3 and above adverse events were reported in more than 63% of patients in the dacometinib, and it also deteriorates the quality of life. Whereas on the other hand, we already have approved third generation osimertinib with far superior clinical profile, be it the efficacy, tolerability, CNS activity, or quality of life. And even the NCCN guidelines, they recommend osimertinib as a preferred recommendation in the first line treatment. So the takeaway points are the Flora trial shows a statistical and clinically significant improvement without any concerns related to the toxicity profile, and with very high activity of brain mets, reducing the comfort role of whole brain palliative RT. On the other hand, second generation TKIs are burdened with toxicity. So with this, I thank the organizers for giving me this opportunity and hand over the session to the organizers.
Presentation and talk. Next, I would like to invite Dr. Kripa Bajaj, who is consultant medical oncologist at Indo-American Cancer Hospital and Research Institute, Hyderabad. And she's going to speak on clinical endpoints and clinical decision-making in mNSCLC. Over to you, ma'am.
First of all, thanks for the organizers for giving this opportunity, especially Dattatreya sir and AstraZeneca. So it's a very interesting topic given to me. There's a clinical endpoints in decision-making in early lung cancer, which is coming up so well. So what's the introduction regarding endpoints in general? It's a primary endpoint, secondary endpoint, tertiary endpoint, three kinds of endpoints will be there. So the objective tools used to measure how beneficial an intervention will be by the patient feeling, function, and survival. Usually the primary endpoints are like chosen to be a survival, a direct measurable outcome based on drugs' expected effects. And secondary endpoints are most likely the quality of life. It may be chosen to explore additional benefit the patient may gain, including the functional and emotional status. Tertiary endpoints are usually post-hoc exploratory analysis. So the types of endpoints can be quantitative or qualitative. Quantitative, as I suggested before, it's a survival analysis like OS, PFS, time to progression. Is based on the time, the amount of time that has elapsed from the randomization to the treatment initiation to the desired event. So quantitative endpoint is always the survival benefit. Qualitative is always like quality of life or subjective feeling reported based on the observation made by patient, caregiver, or physician. So pause for the thought. Are different efficacy endpoints needed in the adjuvant and neoadjuvant setting compared to the advanced mNSCLC? If so, why? So what's the primary goal of adjuvant treatment? What's the primary goal of adjuvant treatment in general? It is to eliminate the micrometastasis. It's not to debulk the disease or eradicate the disease like something like that. It's just to take care of the micrometastasis, to entirely eradicate the disease. It's not just to control the disease, but it's to eradicate disease is the main target of adjuvant therapy. So what's the major problem of adjuvant studies? Why neoadjuvant is coming up so well? Like the data, maybe the debates, whatever neoadjuvant versus adjuvant, whoever debates that, the neoadjuvant is coming up so well. Why it is so? What's the major problem of adjuvant setting is it's typically take 8 to 10 years for the results to be available. So almost all trials, like whatever you take, which got published recently also, it took a long data monitoring for 8 to 10 years to publish the data. With the adjuvant etisol trial or immunotherapy trials, it took a long time to get published. What is the goal of neoadjuvant treatment? It's the goal of neoadjuvant treatment usually is to downstage the primary tumor, potentially making surgery less morbid, and which enables analysis of the treated tumor. So almost all the times, the effect is like on the tumor, it is so visible. Adjuvant, the tumor is not there, but whatever is there, whatever treatment we are giving, it is going to take care of micrometastasis, which is not visible to analyze immediately. It's always survival, which speaks about the quality and effect of adjuvant treatment. For neoadjuvant, potentially the tumor is there. The effect is so visible immediately of the tumor post-resection. So the rationale for neoadjuvant studies in operable NSLC, why it is chosen, why the neoadjuvant treatment is used. And usually the time to rule out the drug is 1 to 2 years instead of 7 to 9 years for adjuvant. As I just mentioned, the effect is like immediately can be analyzed. So what are the surrogate efficacy endpoints used in adjuvant, neoadjuvant NSLC trial? The two types of endpoints are there. One is a clinical endpoint, other is a pathological endpoint. Pathological endpoint usually will be measured for neoadjuvant trials, but not for adjuvant trials for sure. The pathological endpoints used are pathological CR, major pathological response, which is coming up so well, and surgical endpoint, that is the R0 resection rate. So these are the pathological endpoints which majorly contribute to the neoadjuvant trials. The clinical endpoints, it's there in the both neoadjuvant and adjuvant, preferably in adjuvant like this, these play a very important role. That's the OS, DFS or RF, and EFS. So two kinds of endpoint, one is the clinical and other is the pathological. So what are the surrogate endpoints used? The OS is always a gold standard. Whatever treatment we do give, if OS benefit is not there, we do trial to rule out the drug. Not many drugs are there still exist in the market, like where only PFS benefit or EFS benefit without OS benefit. So surrogate endpoint should meet the specific criteria. Surrogate endpoint should predict OS. The treatment effects on surrogate endpoint should predict treatment effect on OS. So it must be validated for the specific therapeutic classes. What are the pathological endpoints in neoadjuvant NSLC trial, which was a debate of discussion all the time in lung cancer meeting. So is the pathological response a suitable surrogate for survival of neoadjuvant treatment? Lot of discussion happened in the breast before, now in the lung. So it currently the era for the lung cancer and the pathological response or major pathological response, whatever is there. The first one, like which got published of analysis of the multiple trials, is 2012 data. There is significant difference in the survival, the RFS as well as OS, when compared to the major pathological response versus no major pathological response. Major pathological response is a response where the tumor residue is only less than 10% of the total specimen. So whoever attained major pathological response, not PAT-CR, it's a major pathological response, they have a significant better outcome is there. So to the brief, PCR as well as major pathological response, all of us know, just now I mentioned major pathological response is only the viable tumor constitutes only less than 10% of the whole specimen, whereas the pathological CR, there is no detectable evidence of tumor based on the histopathological analysis. It constitutes like low pathological CR is like less than 10%. Pathological CR is absolutely no evidence of any disease left. Just like a breast cancer, the same definition holds good here as well. Pathological CR is associated with the OS based on analysis of the patient with NSCLC who received adjuvant chemotherapy. There are two trials, are there, both chemotherapy trial as well as like immunotherapy trial. Immunotherapy trial, I'm not going to discuss in detail, the nivolumab trial, which is like really promising. But in chemotherapy trial, like which was published way before 2012, there is a good correlation between the pathological CR as well as the outcome. So in this, 8% of people achieved the pathological CR with a very good outcome. Major pathological response, again the same, less than 10% of the residual disease, that's a near path CR. Major pathological response, nothing but a near path CR. How it is measured? Again, the same. The examination is measured by pathological examination of multiple H&D stained slides of resected tumor sections. Major pathological response is calculated as the estimated size of viable tumor divided by the size of tumor bed and reported as a percentage. So I'm not going in detail regarding how it will be grossed, how it will be stained, like how you'll assess and all. But in general, the mean residual viable tumor cells, the percentage is number of slides like studied by number of slides, the percent of cells in the each slide by number of slides studied. So that will be the outcome of the response like noted in the different slides, multiple slides. It sums the percentage of viable tumor cells in each slide and divided by the number of slides examined. If you see the right corner, this is the formula for that. So each slide will be studied, the percentage will be clubbed by number of slides studied is the major pathological response, like any pathological response assessment will be done. If it is less than 10%, then it is major pathological response. So what is the evidence for major pathological response as surrogate endpoint in the neoadjuvant setting? So it has shown in the neoadjuvant therapy, which was like mentioned before 2012 data, as well as 2018 data, as well as 2020 data, there is significant benefit for a patient who attained MPR. All these things are going to be repeated again and again in the slides because like multiple publications happen sequentially, which consolidated the evidence that MPR is a very good surrogate endpoint for the survival. What are the pros of PATH-CR? What are the pros of major pathological response? What is the cons? PATH-CR, earlier assessment of treatment effects on EFS or OS, shorter trial duration follow-up, not influenced by treatment administered after recurrence, effects on tumor attributable to treatment, not natural history of disease. The similar replication will happen in the major pathological response as well. So early assessment, short trial duration, not influenced by treatment administered after recurrence, effects on tumor attributable, not natural history of disease. Everything is almost similar like PATH-CR. So what are the cons of it? Not valid surrogate endpoint for OS in neoadjuvant mNSCLC setting. The similar applies to the major pathological response as well. So what is the evidence of benefit of neoadjuvant EGFR TK immunotherapy is limited to small pilot studies. EGFR TK, currently no one is practicing it, but neoadjuvant immunotherapy, I'm sure like many of us have started practicing it, especially nivolumab, the data is like very promising. So all the TKs are failed. Whatever like was done before, like there is some data suggesting, but no data is like so promising. For me, like Nadim data is like seems to be very promising. There's a 59% PATH-CR was there. Major pathological response is 83%. So data from neoadjuvant phase 3 studies are awaited to determine whether improvements in PATH-CR and PR will translate to OS benefits with EGFR TKs and immunotherapies. As of now, nivolumab got established very well as a neoadjuvant option to offer. TKs, there is no strong data to say there is a benefit of OS at all. So only some PFS benefit is there. So neoadjuvant treatment, how meaningful is PATH-CR MPR? Again, it's a kind of repetition here. If you do the neoadjuvant chemotherapy, RT and surgery, observed to date, NeoStar emerging CITOM, neoadjuvant TKR immunotherapy plus or minus chemotherapy surgery, there is an increased PATH-CR MPR with anti-PD-L1 mechanism. There is an uncertain effect of TK, what just now mentioned before. So TK, like we are not still sure, but immunotherapy, there is some data which significant increase in PATH-CR and major pathological response. So the OS will be the final surrogate point. We have to still assess that. But as of now, there is a good data to say that with the addition of immunotherapy, there is a good response are there, which had to be seen translating into the OS. So what are the clinical endpoints in resectable mNSCLC trials? So again, DFS and is same as PFS. So these things briefly we will discuss because the time is very limited. DFS is commonly used as endpoint in adjuvant mNSCLC trials. DFS is a radiological tumor-based assessment. It's time from randomization until disease recurrence or death from any cause, also known as recurrent-free survival. Whereas like PFS assessment is like disease progression. Disease is present at the randomization. So most of them DFS is from the time like the patient underwent surgery, there is no disease at all in the body. From there you do count. PFS is like post, the starting of the treatment, the patient is having a baseline disease, you do give some therapy. Later you assess like till what time the patient will maintain the response. There is no need to say regarding much, much regarding this basic point. Is DFS an appropriate surrogate endpoint for OS in adjuvant mNSCLC? OS and DFS in assessment of adjuvant chemotherapy. So OS is like till the death happened, DFS is just a disease-free interval. So there is a good correlation is there. The correlation with treatment effects on OS and DFS for adjuvant chemotherapy is like significant. It is decent. It has shown to be valid surrogate endpoint for OS in adjuvant mNSCLC setting based on the chemotherapy trials. So there is no PFS in adjuvant. It's only DFS and OS. When you see the correlation between DFS and OS, there is a good correlation is there. It's a valid surrogate endpoint for OS. So evidence of DFS with the EGFR TK in adjuvant setting, select study, all the study which has happened, Sitong study, all happened with the first generation TK. There is no benefit of OS, but there is some benefit of DFS is there. So it hasn't translated to the OS. That's why it is not practiced by any medical oncologist with the first generation TK unless patient is not fit for chemotherapy. So the Sitong trial as well as the select study, just now I showed. So overall evidence for EGFR TK from randomized trials in the adjuvant EGFR mutated NSCLC setting, improved DFS but no OS benefit thus in so far. So the first generation TK I mean to say. So overall evidence for DFS surrogate endpoint in adjuvant trial setting, DFS is again the same repetition. It's a valid surrogate endpoint for OS for adjuvant chemotherapy. DFS is not validated as surrogate endpoint for OS for adjuvant EGFR TK. The lack of OS benefit in trials to date may be due to multiple factors, including heterogeneous patient population, duration of treatment, and level of DFS benefit. So for chemotherapy, definitely there is surrogacy is there. Just now I showed the graph before. For EGFR TK, it hasn't translated into the OS benefit. So there is not much correlation is there for the DFS and OS for EGFR TK patients, like whoever we have given the EGFR TK. The value of DFS surrogate endpoint for OS remains to be determined for adjuvant immunotherapies as data is still awaited from the ongoing anti-PD-L1 phase 3 clinical trials. So EFS as an endpoint for resectable NSCLC trial, EFS is most commonly used as an endpoint in neoadjuvant NSCLC trial. What is EFS? EFS is again a radiographic tumor-based assessment. It is a time from randomization until progression of disease that precludes surgery, local or distant recurrence, or death from any cause. The EFS is measured by scheduled imaging assessment after neoadjuvant therapy to determine response with further scheduled follow-up imaging assessments for after surgery to evaluate whether disease has recurred or not. So EFS, PFS, both are not same. So PFS assesses objective tumor progression, whereas EFS assesses disease recurrence or progression that precludes surgery. So is EFS accepted as an endpoint for regulatory approval? Yes. Treatment effect measured by EFS is accepted as a surrogate endpoint to support approval. Example for neoadjuvant breast cancer therapy given prior to definitive surgery. So OS, DFS, EFS, the pros I will discuss. OS is the gold standard endpoint for clinical trials, unambiguous, very simple to measure, easy to interpret, unbiased measurement. What are the cons of it? It needs a long-term follow-up till the death of the patient. We have to follow the patient, like how good the survival effect happened. Large sample size is needed, affected by subsequent treatments that may prolong life. Patient crossover can happen. A risk of non-cancer deaths rising with the increasing time, like non-cancer synthesis because of comorbidities, accidents, something, natural death, all these things can happen. So these are the pros and cons of OS, but OS is always remains a gold standard for all clinical trial endpoints. DFS, its earlier assessment of treatment effects can happen, shorter trial duration and follow, not influenced by treatments administered after recurrence. Smaller patient cohorts required in trials, less influence than OS by competing causes of death. Delay in recurrence is meaningful to patients because quality of life will get maintained. What are the cons of it? Not valid as surrogate endpoint for OS for EGFR TKs or immunotherapies in adjuvant NSCLC setting, but it is a valid surrogate endpoint for adjuvant chemotherapy because there's a good correlation is there, and what are the graphs and plots have drawn before. The definitions may differ between the trials. Disease recurrence is assessed at scheduled times, but recurrence may occur between scheduled visits, potentially subject to assessment bias. What is EFS? EFS, again, earlier assessment of treatment effects, shorter duration of follow, not influenced by treatment administration of recurrence, almost like DFS, like we can see here. And smaller patients, less influence than OS by competing causes of death, delay in recurrence not meaningful. Again, it's not validated as surrogate endpoint for OS in neoadjuvant NSLC setting. EFS is like for neoadjuvant setting. DFS is like mostly like the adjuvant setting. So this is the major like difference between the DFS and EFS. So EGAN and other randomized studies of neoadjuvant immunotherapy, like all of us know EGAN study, IMpower study, Keynote study, Checkmate 816. To me, Checkmate 816 is a very good study, very well conducted study. So is the adjuvant treatment, how meaningful is DFS? So again, if you see the considerations, adjuvant surgery plus or minus adjuvant chemotherapy, and again the second is surgery plus or minus adjuvant chemotherapy plus adjuvant TK. You have to see the DFS and post-recurrence-free survival. The consideration for adjuvant treatment with DFS benefit is a risk versus benefit of waiting until recurrence to treat, targeting treatment to patients at a greater risk of recurrence. Can we achieve this with surgery, adjuvant chemotherapy plus adjuvant TK immunotherapy? Potential for more potent for TKs with better CNS penetration to reduce CNS metastasis and meaningful improve quality of life during DFS and OS. So for this, I believe like there is a more potent TKs, like we can achieve this. The DFS benefit OS correlation can happen, but other TKs we can't say like there is a good correlation. Even for immunotherapy, there is no good correlation. What are the clinical trial endpoints in resectable NSLC summary? What is summary? I'm just summing up what all discussed before. OS remains a gold standard efficacy endpoint for oncology clinical trials, but requires long-term follow-up and large patient cohorts. DFS has been validated as surrogate endpoint for OS in adjuvant NSLC setting based on adjuvant chemotherapy trials. So there is some evidence for association between PASCR and major pathological response surrogate endpoints and OS for NSLC based on the neoadjuvant chemotherapy analysis, but regulators are yet to be convinced that PASCR and major pathological response correlate with the clinical outcomes. Evidence is needed from large trials to validate surrogate endpoints for EGFR TK and immunotherapy as adjuvant or neoadjuvant treatment for resectable NSLC. With this, I thank organizers for giving this hard topic, like for me as well as to listen for whoever the people attending it. Thanks, Dattatreya, for giving this opportunity.
The wonderful talk and wonderful presentation. Thank you for sparing your time. And now I would like to invite Dr. Dattatreya for the closing remarks. Over to you, sir.
Thank you so much. It was truly an academic feast, and we had a complete overview of how the management of EGFR mutant non-small cell lung cancer, or overall how the management of metastatic NSCLC has seen newer paradigms. We started off with a complete overview of the molecular biomarkers in metastatic non-small cell lung cancer. The role of the anti-VEGF antibody was revisited. And then we had a discussion about the recent advances in EGFR mutant non-small cell lung cancer. We all witnessed the engaging panel discussion by an expert and an excellent moderator. And thereafter, we know that the EGFR TKS are very much efficacious in EGFR mutant non-small cell lung cancer, but with 4 or 5 anti-EGFR TKS available. How does the efficacy, which is almost quite similar, help us in choosing a particular drug, and how do this fare when it comes to adverse events and toxicity profiles? And finally, the entire academic session ended with discussing about how we look at various clinical endpoints, especially in early stage non-small cell lung cancer, how the clinical trial endpoints differ, not only by using different molecules, but also across different stages. I wholeheartedly thank AstraZeneca and the entire event management team for making such a healthy scientific interaction among me and all my medical oncology colleagues. The medical oncology family of Hyderabad has for the past 1 hour 45 minutes truly understood the newer paradigms in the management of metastatic non-small cell lung cancer, and also to some extent early stage non-small cell lung cancer as well. Thank you so much, one and all. And I think it's past 9 p.m. We have been able to complete dot on time. Over to the organizers. I thoroughly enjoyed the entire meeting. It was an academic feast for sure.
Thank you, sir. Thank you, everyone, for joining, and happy Sunday.